adults with serious mental illness, 18 years of age or older, tend to die at a much younger age than the general population that do not have this mental disorder.
In fact, over here, mental health presentations are the number one category of presentations to primary care physicians or general practitioners by a long way compared to any other category.
And the provider looks at sort of what are the critical issues this person have, and they see a mental diagnosis, schizophrenia, bipolar disorder. That tends to create a bias in the provider's mind, like, oh, this physical complaint that this person is discussing may not be a physical complaint, may be related to their mental health.
Particularly because people are, again, more than just their cultural identity, right? And that if you're a Sri Lankan, like my background, your experience of the world is different to another person who is also Sri Lankan, right? So having a bit of cultural humility or curiosity about their individual experience within their culture is important in itself.
So it's really, this is for everyone, in every interaction for your clients or patients. What is that they need? Where's the person in front of me? What is it that they need?
Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment.
Hello everybody and welcome back to the show. Today we are joined by Professor Leo Cabassa to discuss all things physical and mental health inequities. Leo is a social worker and co-director of the Center for Mental Health Services Research at the George Warren Brown School of Social Work at Washington University. Leo has conducted research in the community for decades on health inequities in people with serious mental illness and from racial and ethnic minority backgrounds. In today's episode, we discuss the cycle of comorbidity that people with serious mental illness face, the double health burden that individuals with serious mental illness from racial and ethnic minority backgrounds face, how stigma manifests in practitioner-patient interactions, how practitioners can embody cultural humility in their practice, and much, much more. If today's episode of the Mental Wellbeing College brings value to your life, we would be super grateful if you were to hit subscribe, follow, or to share this podcast with someone you love. Our mission here at the Mental Wellbeing College is to provide an evidence-based resource to people the world over so that they can take action on improving their own mental well-being. Each episode is a deep dive into the research with an expert in the field and looks to extract applicable practical strategies that are still steeped in evidence and research and respect the nuances of the research itself. Another way you can support the show is by leaving an honest review on Spotify, Apple Podcasts, YouTube, whatever platform you're listening to, as that helps grow the show as well. Thanks so much for tuning in. This episode with Professor Cabassa was a real privilege to have. He has conducted some really meaningful research out there in the community with people on the front line. And it was a really, really cool opportunity to dive into his research and to learn so much from him in this hour that we shared together. I hope it's a similar experience for you and brings value to your life. Thanks for tuning in, and now to today's discussion on physical and mental health inequities with Professor Leo Cabassa. Professor Leo Cabassa, welcome to the Mental Wellbeing College.
Thank you. It's great to be here.
Fantastic to have you on. It's been a really wonderful experience reading through some of the really meaningful work that you do, Leo, with people out there in the community. So I'm very excited to dive into your research for the next hour or so. And a lot of the work that you've done is on or with people with severe or serious mental illness. So things like major depression, bipolar, schizophrenia, and looking at some of the health outcome inequities that these individuals face. So can you talk us through some of those inequities and what they are in these kinds of populations, Leo?
Sure. So, Indy, thank you so much for the opportunity to showcase our work. Yeah, we've been doing work for about a decade now, a little bit more than a decade, on examining the physical health of people with serious mental illness. These are people, as you mentioned, people with schizophrenia, bipolar disorder, But on top of that, these are disorders that also impact people's functioning, day-to-day living, and treatments are available and recovery is possible from serious mental illness, but with the right treatments and the right support. And the work that my team has been focusing on is on the physical health aspects of things. So issues around diabetes, cardiovascular disease, hypertension, and what we have known for several decades now is that people with serious mental illness, and we're talking about adults as well, so adults with serious mental illness, 18 years of age or older, tend to die at a much younger age than the general population that do not have these mental disorders. And the majority of the premature mortality is caused by physical health issues, particularly chronic diseases associated with cardiovascular disease. And that has been a long-standing inequity in this population, particularly in the United States. That's so where we do most of our work as well. Yeah.
Yeah, and as I understand it, this premature mortality is a gap of around 10 to 20 years that they die earlier compared to people without serious mental illness. So quite
That's
stark.
exactly right. Between 13 to 30 years, depending on the data that you're looking at. And this has been documented worldwide as well. So not only in the United States, but in other countries as well. And this mortality, and what we have seen is that the mortality gap seems to be increasing over the decade. So the efforts that we've seen for the general population to improve cardiovascular health, for example, have not completely reached the population of people with serious mental illness. So they're not benefiting from the efforts that are being done to address these inequities in that. And then a lot of our work focuses on racial and ethnic minoritized groups, so Latinos, Blacks in the United States, and the impact that minoritized status and the historically underserved population impact those populations in many ways.
Yeah. So I'm curious. I had Dr. Oscar Lederman, on the podcast recently, and he was telling me about this the health inequities between people with serious mental illness and those without, and how it's quite under recognized here in Australia, and perhaps doesn't receive the same amount of attention that, say, a similar health gap between our Indigenous and our non-Indigenous populations have. In the States, is there much attention to people with serious mental illness and their premature mortality and these health inequities?
So it's been a similar sort of journey as you can see in Australia. The inequities in people with serious mental illness received attention maybe about 10 to 15 years ago, became a really big topic. There was a major report that they looked at the physical health of people with serious mental illness in the public mental health system in the United States, and that's where you see this statistic that people use: people with serious mental illness dying 25 years younger than the rest of the population. So that report it was basically the directors of mental health services, commissioners of mental health throughout the United States, an association that makes that report, and actually came down with that statistic. And then many different projects and groups around the nation began to document and really delve deeply. In our book, actually, we go back and we know that the inequity between people with serious mental illness and not go way back. There's reports in the 1930s of that disparity happening between people with serious mental illness and people who are not, looking at medical records and hospital records. And the causes of those inequities also were physical health issues. So it's an issue that's been there, but it didn't receive the attention of funders and providers and clinicians and advocacy groups until about a decade ago. And then there's been quite a lot of progress being done, particularly in the United States, around this. And then in Europe and in other countries as well, this has become a major issue with that component.
Yeah, and in terms of more attention to it and developing a bit of a deeper understanding as to the health outcome inequities, there are some understanding now as to why this may occur, and you alluded to it earlier in terms of I think cardiovascular health is really really poor in these kinds of populations. It's not typically higher rates of suicide as one might think off the bat. It's the underlying physical health. So can you talk us through that relationship there, Leo?
Yeah, oh, for sure. So the issues that are impacting disproportionately people with serious mental illness have to do with chronic illnesses, and these are related for more. There's a we call it a constellation of factors that influence that. So you have issues regarding your diet, your exercise, lack of physical activity, poor dietary practices. You also have high rates of smoking as a major driver of this premature mortality. In fact, the majority of people that are smoking, there's statistics out there that have some serious mental illness. And the rates of smoking, particular smoking nicotine, has continued to increase in this population. You also have the metabolic, the cardiometabolic side effects of antipsychotic medications in particular that create weight gain and issues with your cholesterol and blood glucose levels, basically, that if they're not properly managed, can create the serious inequities. And then you have also aspects of people with serious mental illness based on where they're living. Also, their environments create an issue here. So if people are living in poverty, in areas where you have low access to nutritious food, not have enough safe spaces to exercise and be physically active, all of those things compound. So we call it, in fact, we have a very complex problem on our hands. It's a constellation of factors that interact with each other to impact the physical health. And then I will say the last component of that also is the lack of attention to the physical health, to the health care of people with serious mental illness. So most people are receiving care, their mental health care, and receiving medications and psychosocial intervention, but their connection to primary care, their connection to preventive primary care also is lacking. So that also influences and contributes to this premature mortality, that lack of access to good quality healthcare as well. So all of the things sort of play together to create these inequities.
Yeah, and I certainly want to dive into some of those factors that tie into the constellation, like you alluded to there. So, if we start with, say, the lifestyle behaviors, it seems like a lot of these cluster together in terms of low physical activity, higher rates of food insecurity or poorer diet quality, higher rates of substance use, so things like tobacco, illicit drugs. So, yeah, it seems like if you have one of these, you're more likely to engage in another one of these, and they contribute to that poor physical health outcomes.
That's exactly right. Yeah, we have turned it to the cycles of comorbidity, where this influences each other. Lack of physical activity may be because part of it has to do with lack of motivation that happens with some of the serious mental illnesses, which then influences your levels of engagement of physical activity, which then will impact your physical health and goes into this cycle of unhealthy behaviors. Same thing with like substance use, using it as a way of coping with some of the physical health or mental health issues that someone is having, and then engaging in those substances, which can impact their physical health and going round and round. So it's really these interactions between these different factors that really impact this, and it creates these complex problems for the population. And then if someone is not paying attention to their physical health, is more of the attention professionally is going to your mental health, and your physical health is not being managed or is not being paid attention to, then you're going to have serious issues as well. So those are some of this complexity of factors that come into play. And when you talk to clients and people with lived experiences, they don't talk about their health and their mental health. They talk about their being. That it's all one person, one human being. And in our system of care, particularly in the United States, we separate the health from the mental health. When in fact, people talk about the whole body, the whole mind, the whole person, and our service systems separate those and create barriers for dealing with your health and your mental health at the same time. So that's the other component that also plays a role here. You have to go to different places to take care of your body or your health and your mental health with it.
So different people working in silos, and it's difficult to communicate with each other, these healthcare practitioners, right?
That's right. And it's left to the individual to make sure that that's being
Yeah.
coordinated. And you put on top of that psychosis, depression, and some other things, and it creates a real big issue. We call that fragmented care, and the person falls through the cracks. in time. And this population is the one that tends to fall through the cracks more in this process.
Well, I can imagine that can be overwhelming, right? If you're dealing already with a serious mental illness, with the symptoms of, major depressive episode, to have to deal with coordinating different appointments, different medications, yourself, and essentially advocating for yourself to get your practitioners to talk to each other. I mean, that can be a challenge in itself.
That's right. That's right.
You've alluded to this a couple of times in terms of people who might have a serious mental illness and perhaps their physical health is overlooked. And again, referencing something that Oscar taught me in a previous episode, diagnostic overshadowing.
Mm-hmm.
Can you talk a little bit more about what that might look like from an appointment point of view, from a practitioner point of view? Why would their physical health be missed, be overlooked?
That's a great component. So part of what's happening in a health interaction, so you can think of multiple factors that influence here, but our critical one is the interaction you're having with your provider. Like, how do you present the information, your symptoms, your complaints, your needs, and how the provider interprets that. And it's really interesting that when a person with serious mental illness goes and seek medical care from a provider that may not know them, so let's say they go to the emergency room, and the provider looks at sort of what are the critical issues this person have, and they see a mental diagnosis, schizophrenia, bipolar disorder, that tends to create a bias in the provider's mind, like, oh, this physical complaint that this person is discussing may not be a physical complaint, may be related to their mental health. So the provider creates this bias, and that's why it's called diagnostic overshadowing. The physical health overshadows, the mental health, overshadows the physical complaint. And in our work, we've seen that multiple times. We've seen that it's a common bias that providers have, and it's not that the provider is being rude or that the provider is not I don't want to fault the provider here. It's just that in a clinical setting, you're making quick decisions, and if the person doesn't have the full picture of the individual, if the person doesn't have the right medical history, this could create some serious issues. So, for example, we had examples of people going to the emergency room complaining of a stomach ache, like their stomach hurts, and they say, oh, that's on your head, that's not, and they see you're taking antipsychotic medication, you have schizophrenia, that's probably part of your, you're making this up, or that's not a real symptoms. And then when in fact the person is having a painful reaction to something, they may have appendicitis, they might have something going on, and that gets overshadowed. So it's that interaction that creates this, and it's in the interaction between the client and the provider that creates these issues, and then creates to poor diagnosis that then could lead to the wrong treatment that the individual. So that influences that process as well.
Yeah. And again, I think you alluded to this here in your response, but I imagine the environment with which the healthcare practitioner works in is important, in the sense that, at least here in Australia, our physicians, or as we call them, GPs, general practitioners, are very overworked. There's extremely little time to see patients. In fact, over here, mental health presentations are the number one category of presentations to primary care physicians or general practitioners by a long way compared to any other category. So to have the time to dive into the physical health component of someone presenting with a serious mental illness can be difficult if you're working in a stressed, overburdened system.
That's exactly right. So how do we support providers within that system to address these issues? So providing them the right information, training them on how to create these interactions with people with serious mental illness can help in that overshadow. If the person comes with a family member who can advocate for the care, if they're coming with a healthcare manager or a case manager who knows the history and can provide that information more clearly, can help with some of these structural issues in the environment that the provider is working on. The other thing is training general providers to work with people with serious mental illness in their medical school, in their training. Usually when we train people in medical school for people with mental illness, they only see them in the hospital. They only see in inpatient care, which is usually, very important, don't get me wrong, but it's a very different interaction if you're seeing that out in the community. So providing more training about working with people with mental illness can also address some of these issues.
And on that point, I know you've spoken a lot to patients, clients themselves. Have you talked to physicians as well? What's their opinions on their roles and what they need? Is it that they say that I do need more training and that's what's lacking?
So that's one component. Yeah, in many of the studies, it's really important to understand all the different players here and their perspectives and their views on this. So, for example, we have a project right now with a great colleague in Puerto Rico, Elio Rivera Segarra, who's looking at diagnostic overshadowing and stigmatizing behaviors. So he's developed this wonderful training program where they're showing medical students, like, here's an example, here's a video of a stigmatizing interaction between a doctor and a client, and they see, oh my god, this is what's happening, these are the issues. And then here's another example of a destigmatizing interaction. Here's what you should do, and let's practice it. Let's deconstruct that. Let's teach you the skills, and then they practice it with a standardized patient, so that they not only know about the knowledge of what to do, but practice how to do it. So that's one approach that providers can help with that. The other component is sharing information. In some of our projects, for example, we've used this idea of a personal health record, which is basically is your health record for yourself, and you can carry that. It's a little piece of paper. It tells you what your medical conditions are, what medications you're having, what are some questions that you may have for your provider, and that you can share that with the provider ahead of time, and so they can see what information you have. So that sharing of information can help reduce this diagnostic overshadowing and create a better interaction between the client and the provider, the patient and the provider in some way. So there's ways to sort of doing that type of work that I think will be very helpful. The other piece here, it's from the other side, which is from the mental health side of mental health providers like social workers or psychologists actually not paying attention to the physical health component. And part of it is because they're not trained on addressing the physical health issues. So you see this weird sort of dilemma of professional boundaries. You have a client, you're dealing with their mental health, they have a physical health complaint. Whoa, I'm not trained to do that. What do I do? That's not my job. I'm not trained to do that. So who's responsible for it? And then vice versa from the other side, a person with serious mental illness has a physical health issue, but is complaining of mental health issues. Who's addressing that? We call that professional boundaries. And part of that is that you have to work in a team together across different disciplines and different professions to address the needs of the individual. That also influences. So there's a lot of complexity in terms, but there's ways of addressing that complexity to address the whole person, the whole needs of that individual, to address this.
Yeah, that's really interesting, the side of the social worker or psychologist that you bring up, Leo, because I think even in my own training, this kind of information was largely not really relayed to us as future clinicians back then when I was training. So perhaps a lack of awareness, but also, like you said, a lack of not wanting to go outside your own scope of practice. So most psychologists, social workers I know are really well-meaning. They get into the profession, they want to help people, but also don't want to. There might be a fear of not wanting to do damage or not wanting to go outside of your own scope of practice. And how do you overcome that?
That's right. And it's interesting. We've had the good example that we have here is that there's like a tipping point. So if you're a social worker, you have someone that you're caring for the mental health of that individual. But if there's an acute crisis, the person's having a heart attack, the person is fainting, the social worker immediately, oh my God, there's a physical health issue here. We need to call the doctor. We need to activate. And for acute, immediate issues, we're very good at that. But what we're talking about is chronic illnesses, things that linger over time. So someone's hypertension, they might not have a heart attack in front of you, but their blood pressure might be up. They might have symptoms. And it's how do we move that tipping point towards more chronic illness management, that everyone in that team understands the person and what the symptoms are, what their needs are, and how to help coordinate and navigate that individual to the right providers, and providers talking to each other around these particular issues. That's one way that we have tried to address these professional boundaries, and look at it from a chronic illness perspective rather than acute issues that come up, or just crises.
Yeah. So I want to actually double click on something you mentioned earlier about stigma and bring this back to what we're talking about here as well. So you mentioned that sometimes people feel stigmatized in their interactions with healthcare practitioners, and I'm curious. Do you find that people with serious mental illnesses are sometimes avoidant of seeing their physicians or their GPs because of these interactions they have where they feel stigmatized, or they feel like the GP is a know-it-all, or there's a level of mistrust I think I read about in your work, but that they're more open with other practitioners, say they're psychologists who they might have a bit of a deeper relationship with, compared to say their physician or general practitioner.
That's exactly right. Yeah, there are some instances of that, and here's where our work of serious mental illness and then the race, ethnicity, your background, your identity also plays a role. These things are interacting with each other. So that also plays a role on how you react to the system. So, for example, that level of mistrust, if you have an interaction with a provider, go to a hospital, go to a primary care clinician, and that interaction is negative, you may, and we've had seen this where clients are more reluctant to seek help later on because they are fearful of what that interaction may look like in the future. So those personal interaction become really important. The distrust is also really critical. If the person has been discriminated against because of the color of their skin, because of the language that they speak, because of their immigration status, that also influences people's interaction with the healthcare system, and that may be more reluctance to go seek care, or wait until this situation is very serious for them to seek care rather than trying to prevent a situation or seek care when things are not as bad. So all of those things play a role here. And so we have to also pay attention to these other biases that are in the air, that are part of the healthcare system in which these providers live and participate. Yeah.
Yeah, so now we're kind of double clicking on this term that I've seen you coin, double health burden. I don't know if you originally coined it, but you were the first person that I've seen coin it.
Yeah, I didn't coin that. Yeah.
Okay, you can't take credit for it. Okay, no worries. So the double health burden of individuals with serious mental illness who are also from a racial or ethnic minority background. So let's dive into that a little deeper. So we talked about stigma when they're with a healthcare practitioner, and like I said, every social worker, psychologist, GP that I know is well-intentioned, well-meaning. So when we talk about stigma, are these individuals experiencing just overt racism, racial comments, derogatory comments, or what kind of stigma is occurring in these interactions?
That's a great question indeed. So it's a little bit of everything. Sometimes it's very overt. Sometimes it's right on your face that not being treated because you don't speak the language. For example, we work with a lot of the Latino community, and some of my work was in New York, so Dominicans and Puerto Ricans, and people may not speak English very well, and they may be discriminated because of that, because of their language issue or their immigration status, or an assumption that people are making, you don't speak the language, you're not from here. So that there is overt discrimination that happens in that prevents the person from engaging in care, and also prevents them from getting good quality health care. So, and on top of that, you have the serious mental illness. So these things are interacting with each other. One thing that we have tried to elevate in our work, and we saw this in the literature, which has been, to me, an ongoing challenge, that there's this assumption that once this inequity that we've talked about, people with serious mental illness dying much younger than the rest of the population, but people are more than their serious mental illness. They have their identity, their race, their ethnicity, their culture. All of those things interact to create some of these inequities. And they might be, in the United States, we know that certain groups have already a higher probability of having health inequities. Latinos with diabetes, Black populations with obesity and hypertension. And you put on top of that the issue that we've been talking about, serious mental illness, and you might create this double or triple burden of issues that may come up. So what we're trying to do in our work is to make people aware that, wait a minute, you have a serious mental illness, but you also have these other identities that could be interacting with all the things, and we need to pay attention to them so that overt discrimination doesn't happen, so that stigmatization is reduced, and that we're paying attention to those type of components. And some groups may be even at higher risk than other groups because of those inequities that are happening, racial and ethnic inequities that are happening in our system of care. So we're trying to sort of bring those things into attention with this work as well.
So when you say attention, then, is this almost referring back to the diagnostic overshadowing of that if an individual with a serious mental illness comes to an appointment or sees a healthcare practitioner, that healthcare practitioner, coming back to the bias you alluded to earlier before, sees them only for their serious mental illness and not their other identities? Is that kind of what's occurring in terms of that lack of awareness?
Yeah, Indy, that's a great question. No, I wouldn't call that diagnostic overshadowing, but it is this idea that we're prioritizing one thing over the other rather than what the individual needs. So, for example, if we're doing interventions, a service system, or let's think things around diet and exercise, right? And and all I'm thinking about is your serious mental illness. You need to increase your physical activity. You need to eat better. Here's like a one-size-fits-all recommendation for you. And we don't take into consideration, but wait, you may live in an environment where exercise and physical activity may not be appropriate, may be unsafe. The dietary recommendations that I may be giving you may be culturally inappropriate. That's not the food that you eat. What do you do with this type of recipe when you eat this sort of thing? So if we take that one-size-fits-all approach, we tend to miss those little things that make a huge difference in a person's life, particularly a diet. If I give, and this happens a lot in the work that we do, here's the dietary recommendation. They're usually for a white middle-class person. Rather than, a Latino with low income or a Black person that eats different types of food. Culture and food are so intertwined that we need to pay attention to that and the recommendations that we're giving you. So that's one example where the things come into play. The other example actually is in the interaction between a doctor and a patient, right? And there's some cultural aspects to that. In the work that we do with Latino clients, there's this issue of deference to authority. Your doctor is an authority figure. You don't argue with your doctor. You don't contradict your doctor. So when you go to the doctor and the doctor tells you need to do X, Y, and Z, most clients will say, yes, I'll do that, doctor. Yes, I'll do that. And then go home and do whatever they want, right? And not follow instruction. And if the doctor is not aware that that's the dynamic that's happening, they won't check on it. And then if the client is not adhering or not complying with the instruction, they might say, oh, this client is resistant to the recommendation. And it might not be nothing like that. It's that we haven't checked around that. So culture sort of embeds itself into all these different interactions. And we need to sort of make them come to the surface so that we can create better services, better opportunities, and better options for people that are tailored to their own needs and their own realities. Is what we're trying to do with some of this work.
Hello everyone, a quick break from today's episode. At the Mental Wellbeing College, we are committed to the goal of communicating evidence-based wellbeing strategies out to the broader community. The goal of this podcast is to bridge a gap between self-help material and peer-reviewed research by providing evidence-based discussion that respects the nuances of psychology but is digestible for all audiences. Ultimately, I hope that you as a listener feel empowered after each episode so that you can take away and implement strategies to improve your own mental well-being. If you have gained value from this episode of the Mental Wellbeing College, I would be so grateful if you were to hit subscribe or follow, or to share this episode with someone that you love. This is how we continue to grow the show, get the message out, and to impact people in need by providing such information and strategies. Thanks so much for tuning in. It means a lot to us here at the Mental Wellbeing College. And now back to today's episode.
Yeah, okay, that makes complete sense. Yeah, and the example you give there of deference to authority, so kind of avoiding any disagreement or confrontation with an authority figure, but it might on the surface seem great, but then if they discontinue treatment or don't follow or adhere, like you said, then they're not getting the outcomes they need.
That's right. And one way to address that is actually to raise that issue. It's like, no, you can disagree with me as the provider. This is sort of the options that we have for treatment. What do you think of those?
Yeah.
What may be helpful? What may be not? Do you have any questions around this? It's okay to ask me questions. So if you come with that perspective in mind to interaction, you're going to have a more productive interaction with your client. If you know that beforehand or have assessed for it in the interactions. So yeah, it's things like that we're trying to disentangle and make it more explicit so that then we can do something about it.
This is one thing I am grateful for in my own training as a psychologist is this shared decision-making model. Is we get taught, a lot on how to account for patient culture, values, preferences, right. And that, to really stay away from the paternalistic model of you as the practitioner or the expert, you dictate, you tell them everything. No, it's a shared decision and giving them treatment options, which they understand, rather than just here's this one thing you need to do, allows them to take autonomy in their own health.
That's right. And that's a great example of a shared decision. Shared decision making is very valuable. But for example, if there's no trust between the provider and the client, shared decision making goes nowhere, right? Because I don't trust what you're telling me, you don't trust what you're telling me. So we have to build that trust in order to get to the shared decision making, and then we can do it. So it's all these little things that make it component. But if the provider is not aware of that, and the client is also not aware that, this is what's happening. This is a shared decision. This person is telling the doctor or the provider is giving me options. I am looking at those options. Then we have a conversation, figure out what works and not. And this is a negotiation into this process. Then this becomes a more productive interaction. So anything that distracts from that interaction could create problems.
Well, yeah, and another reason why this kind of shared decision-making model is important, which I came across in your work, is certain cultures might typically have beliefs about certain treatment options. So, for example, medications being either bad or addictive, or I read in one of the chapters in your book, A Call to Action, that certain people have an increased likelihood of believing that if they take medication, this is an admission that I'm having a severe problem, and that creates a barrier to taking medication in itself. So can you talk about some of those cultural beliefs?
Yeah, that's exactly right. So the idea, people have conceptions, and this work comes from cultural anthropology and medical anthropology, from clinical psychology, health psychology, in a way that people have sort of representations and ideas of their illness and their treatments. So if people may have an idea, if I take this medication to get better, I could get addicted, or this is I am taking medications for a problem versus some other solution. This is a mark of shame or a mark of deficiency from the person's side. So not knowing that may create these issues. So bringing those conversations into the foray to the upfront and having this discussion. No, this medication, you need to take it because this is how this medication is working. It's not that you're becoming addicted, it's that it's needed for the type of issue that you will have, for your hypertension, for your diabetes. It's part of your helping your system, your organs, your system to work better. So it's really having those discussions and bringing those things to the forefront so that then they can be addressed. In some of the work that we do, and sometimes the provider might not be the best person to do that. It might be someone from their community who can explain that to people, or someone that have lived experiences and can say, yeah, this is this concern that I have. This is how I overcome that concern or address that concern as a way. So different ways of addressing those types of issues becomes really important for that.
I'm curious how much of the work in racial inequities or inequities in ethnic minorities you've done in terms of more traditional psychotherapy settings as well. So, like reading through some of Dr. Jesse Owen's work on the multicultural orientation framework. I don't know how familiar you are with that, but
Mhm.
the idea that um, assumptions from a psychologist or from a practitioner's point of view made in that setting can also lead to ruptures in a therapeutic relationship, can also damage that if you have um, wrong or stereotypical beliefs, particularly because people are, again, more than just their cultural identity, right? And that if you're a Sri Lankan, like my background, your experience of the world is different to another person who is also Sri Lankan, right? So having a bit of cultural humility or curiosity about their individual experience within their culture is important in itself.
That's exactly right. So I'm glad you're mentioning this, Indy, because it is really important to take this in a like individual by individual person, right? Not all Sri Lankans are the same. Not all Puerto Ricans are the same. We don't want to stereotype people based on their identity. So one approach that we've used that comes from Roberto Luis Fernandez's work and others is the culture formulation interview. And we've adapted that to health. This is actually part of the DSM-5, believe it or not. But it's really this idea of like, let's tell me about what do you think causes your particular physical health issue? What do you think causes your diabetes? What have you done about your diabetes? What do you fear most about your diabetes? Who can help you? What have you done? And begin to bring that story out into the forefront for the provider to understand. And we've done that with physical health issues. We've adapted it to physical health issues. And it's been fascinating to see what people come up. First of all, that providers rarely have the time to ask these questions of their clients, right? You mentioned much earlier, like general providers have very limited time to address health, mental health issues, and everything else. So we need spaces for clients to tell us their stories, to tell us what they think personally. And that has been a really interesting approach. I'll give you an example from some of our work. We have the social workers in an outpatient mental health clinic. They've known these patients forever. And they were treating a particular client that had diabetes and hypertension. And the person's like, oh, we don't need to do this interview because this person has had hypertension and diabetes. They know exactly what it is. It's like, no, do the interview, see what it comes up. And what comes out of that interview is that the person knew very well about diabetes, but when they talked about hypertension, they're like, oh, I only take my medication when I have a headache. Hypertension just means that I have a headache. It's like, oh my God, no. We need to
Okay.
then talk about hypertension. What are the symptoms? What are the signs? What are you taking your medication? How to support that person around that. So something that we may think we know may not know if we haven't asked those questions. So that's just one approach for doing. And I think the right frame of reference is to be very cultural humility. We're never gonna know everyone's everything, every culture. No, we need to be humble and understand and try to get at what this individual needs in front of us in a clinical interaction to then address those issues. So those are some sort of aspects of how we have tried to do that. And it's been really interesting to see how then you can use that information and help then craft an individualized plan for that person to address their needs.
Yeah, so rather than having an expectation that healthcare practitioners know everything about every culture, it's about teaching them a skill set of curiosity, a skill set of questions, like in this framework,
That's right.
to be able to lean into the individual they see before them.
That's right. The other approach
Yeah.
that we've used is peer specialists. So people with
Okay.
lived experiences that come up with a very different perspective. They have lived through this. And we have partnered with peer specialists in the United States are people with lived experiences. They've recovered, they have schizophrenia. They've recovered, for example, they may have schizophrenia. They've recovered from schizophrenia. And then they've been trained to work with different clients and different interventions. So they bring that perspective in and they're able to then communicate at a very different level than a provider could that haven't experienced, that haven't had that lived experiences with schizophrenia and diabetes. What does that mean? I mean, we can read all the papers we want, but if you haven't had that experience, it's a very different type of credibility that you bring into the conversation. So that's another approach where we can bring that to this. And in some of our work, the peer specialists have been fascinating to deliver this intervention in a whole different manner that we wouldn't have thought as researchers or practitioners. And that doesn't mean practitioners can't have their own lived experiences, don't get me wrong. That's also out there and could be very helpful.
Yeah, no, it's really interesting to read through some of the interventions that you talked about in some of your work, and I want to double click on them in a second as well. But before we do, I would like to ask you a little bit about some of the more cultural beliefs that individuals might have about their, particularly about their mental illness. Looking through your work, some of the God's will or the karma hypotheses. So the way that people see the causes of their mental illness can be culturally valenced and influenced as well. Can you speak to that at all?
Yeah, of course. I mean, people come with, and we don't do a lot of that work in a sense, but it's this idea that people, as I mentioned, have their own exploratory models, their own views of the world, their own views of where their illnesses come from. And by having that information, I think it's really important. For example, someone that's very religious or spiritual, and they say, this is an issue from God or something like that, or part of their, everyone in the family has this. It's an issue that will come up. Some of the work that we've done is like, yes, okay, now we know, we understand that. How can we use that to engage you in care? So, for example, I'm recalling of a participant who was very Catholic, very religious, and talked a lot about her spirituality, and she was resisting treatment. She was like, I don't want to do this, and in a way, we turned it around. It's like, well, God helps those that help themselves. Trying to put her in sort of her same belief system, or trying to find a way from her belief system to help them. That, yes, God is helpful. Don't get me wrong, pray and do all of that. But you also have to help yourself as part of that process. And by framing it in that way, we saw a shift in that person's perspective. Like, oh, that's right. I have to also do something to help me, and this is the opportunities that the person has. So it's understanding those pieces that I think may be helpful. But that's an area where other people are doing better work for sure in that.
Yeah, I'm glad you brought up that point. That's really fascinating, because some of the questions that I have when reading about this particular lens is how to approach it from a practitioner's point of view when the individual's cultural beliefs or their beliefs about their etiology or their treatment might not be best from a symptom point of view. So, for example, if the best evidence-based treatment for someone with their condition at this point in time is medication, but they're completely against medication, or if, in some cultures, talking about your problems, your whether it's mental illness related problems, for example, actually they believe that might make it worse, and that you need to kind of ignore it or just kind of get on with it. And therefore, psychotherapy may not be the best option for them. So how to kind of navigate that from a practitioner's point of view when your view of what's a most evidence-based treatment doesn't match with their beliefs?
Yeah, so I think, for example, the medication one is that one that we've had some experience, where a person may say, I'm depressed, and the first line of treatment that I have for you is a pill. But I'm depressed because the person is saying my job, my family, my other issues, and now you're giving me a pill. How is that going to fix these aspects of it? So then, okay, that's a really important distinction. That's really critical. Let's explore that further. So it could be, yes, you're right. This pill's not going to fix all of those problems, but this pill may help you sleep better, so that then you can take better care of other things in your life. Or you're right, you may need other services around you. Psychotherapy might not be all that you need. You may need a care management or case manager to help you with your housing issues or paying the rent or things like that. So it's really understanding all the complexity that the person has, and then figuring out what those interventions are, and being in partnership with that individual. That, I guess, that's my social work hat coming in right now, to understand that. But that is the person and the environment, and then where is that person at? Meet them where they're at, and then go one step at a time, for addressing these issues. And usually, when you find one thing that helped, then the person is you create better trust with that individual, so that then you can help with other things. So it's things like that. The medication is a critical one. When we worked many years, I worked many years, in a study on diabetes and depression in the Latino community, and this was an issue. People did not want their medication, but in that study, we had an option where people can get medication and psychotherapy, or just psychotherapy. So we gave them preferences, and that's the way that then we help them figure those components out. If you get people what they want, they're more likely to do it. So the person wants to start with psychotherapy, let's do that. Let's start with that. And if things are progressing well, we'll continue that. If things are not, then hey, here's another option. We can add medications given what you have. Let's look at your symptoms. These medications can help you with X, Y, and Z. And we can continue psychotherapy. So trying to figure out what that person needs, what are their conceptions of the problem, and how to find better fit with that. And within the realities and the constraints of where people are working, and what's available also becomes an issue.
And in terms of one of the things that I'm seeing from the examples that you're giving, Leo, it seems like a really good skill is to frame the treatment options in a way that they connect with. So, you talked about, God helps those who help themselves, and medication might help you sleep better, which might help you with those responsibilities you've got going on in the background. So the way that you conceptualize the treatment and provide feedback to the patient, making that in a more relevant way for the patient, will increase adherence.
That's right. We hope. That's exactly right. That's a hope of what we have. Also, what are the social supports that person may have, if they have any, how to activate them as well and help them. So yeah, it's trying to find that fit, and it may work, it may not. People may, the idea here is you're providing options. You're like you mentioned, the shared decision making. Here's all the options that we have, how to make this work for you. But you need to be aware of those cultural issues that come up, or those barriers that may come up. And we need to train providers to be humble and be asking about those questions and those things.
So let's talk a bit more then about the interventions, and kind of, we've talked a lot about different components about how practitioners might go about accounting for these health inequities, but also cultural preferences and being aware of these preferences. Are there particular interventions that you can shed some light on that encapsulate these principles?
Yeah, so we have a couple. So it's a healthcare manager intervention. So it's this idea that people with serious mental illness, they're in the outpatient mental health service, so they're in the mental health system. They have a physical health issue, diabetes, cardiovascular disease, hypertension, and they need to navigate to the primary care setting. So how do we help coordinate that care? And in usual and routine practice setting is the person who's doing that navigation. They go from one place to the other. They inform their clinicians about what's happening. And as you can imagine, things can fall through the cracks through that. So one intervention we have is providing a healthcare manager, a social worker, a nurse who's helping in that navigation and that care coordination. And the idea is that individual is helping the patient navigate and integrate what they're learning and the services that they're receiving, so that what their psychiatrist is telling them and what their primary care doctor is telling them is all taken care of, and is being integrated into one treatment. And then also sharing information between providers. If there's a change of medication from the psychiatrist, that the primary care physician also knows that there's been a change, and vice versa, so that everyone is sort of communicating and engaging with that. And the healthcare manager then is helping and encouraging and motivating the client to engage in their healthcare. And that has been an intervention that was developed by Ben Dross in Atlanta, Georgia, called P-Care, and then we adapted it to Latino clients around these particular issues of cultural issues, assessment, understanding the identity of the individual, and things like that. And we adapted, the original intervention was actually for nurses, and we adapted it for social workers. So also expanding the providers who can deliver this care also becomes very important. So that's one intervention of navigating between the system. There's been other where instead of having two different places, you integrate them into one clinic. The behavioral healthcare homes where they're all in one place, and the person doesn't have to go to different providers and different places. It's all in one building, and everyone sharing information. That's another approach for doing that. So those are interventions around the healthcare. And what we found is that people got better activated. They got more engaged in their own healthcare. They increased their confidence that they can talk to their doctors, that they can do something about their physical health. And then we almost double the rate of preventive primary care, so vaccinations, screenings, that type of thing. So people were getting the care that they needed for this particularly. And this is all for people with schizophrenia, bipolar disorder that also have cardiovascular risk factors. So they were either smokers, have diabetes, had obesity, high cholesterol, any of those things play a role here. So that's one type of intervention where this is paying attention. And then the healthcare managers were social workers. They were bilingual. They spoke English and Spanish. And they use all these different techniques that we talked about to engage the client into this process. And we keep going, but client and patient, it's just my social worker and my psychiatric.
Yeah.
How do you, what term do you use in Australia? Is it clients, patient? Yeah.
Yeah, so as I'm trained as a psychologist, we are taught more to use the term client, but in saying that, I work a lot more in private practice, so I would assume that psychologists working in inpatient wards in a hospital might, be more inclined to use patient. So it probably depends on the setting. Yeah, but I remember we had almost like a whole 2-hour workshop just on our psychology training on what should we be calling our clients, what's the right term to use, because words do carry meaning, right? So
it does. It does. So you can see I'm shifting from one or the other because it is multidisciplinary. It's working with different systems and providers.
Yeah. So some of those interventions at the practitioner level and getting them to talk to each other, they sound extremely important. And I'm wondering if there are any in Australia. To be honest, I don't know off the top of my head. Are you aware of anything similar in Australia? Or?
Not that type, actually, because of it. This is very unique in a sense for the healthcare system in the US that is so fragmented, and that people need this navigator. Patient navigator is another way that people talk about. Care coordinators is the other way that people talked about around this. But this is in that unique perspective of mental health and primary care separated from each other, and this is one approach for helping that process. Yeah.
Have you seen any approaches at the tertiary or study level in terms of teaching future clinicians, whether it's social workers, psychologists, or GPs or physicians, to be more culturally humble, to be more aware of the need to integrate different cultural preferences into their practice?
I think, many years ago I was in a faculty member at Columbia University in the Department of Psychiatry, and the residents, for example, psychiatric residents will take a course on the cultural formulation component, how to integrate that into their own care. In schools of social work, there's a lot of cultural humility. There's a lot of things about health equity, social justice, addressing sort of the cultural aspects of care, different courses that are provided. But at the end of the day, actually, it's also in the practice, like people out in the learning how to apply these concepts in their everyday practice. So in social work school, we have practicums that students take and they practice the skills with that. So there are courses, there are training components and approaches for this. How well they're used throughout, that's a whole other question, but yeah.
Yeah, well, in psychology, we do get trained a fair bit. It's embedded within us to, culturally adapt treatments that they call it. But I think the best advice I ever received was to embody cultural humility in your everyday life, because it's difficult to just turn that on when you're seeing a client, or to almost to fake it or to manufacture it. You need to embody that all the time, and use every opportunity as a practice for that.
Yeah, and for every client, that to me, actually the biggest cultural issues that I've had with clients are actually other Latino clients.
Oh,
That
really?
even if
Okay.
we're Latino, even if we speak the same language, we still have a cultural difference. So it's really, this is for everyone in every interaction for your clients or patients. What is that they need? Where's the person in front of me? What is it that they need becomes really important. Because that's the other thing that we see, that we only talk about cultural things when it's the other, when it's not ourselves, when it's not the majority. And in fact, everyone has culture, and all these things come into play for everyone. And so how to do that, and cultural humility, I think that's what you're referring to, Indy, which is really good, which is like being that frame of reference in every interaction that you're having.
Yeah. No, I love it. Very sound advice, because I think a lot of future clinicians and clinicians in training do listen to this. So, yeah, very sound advice there, Leo. I'm wondering as well, just finally, one of the really interesting things reading through your research has been the type of work that you do. You do a lot of qualitative research, a lot of implementation science research. So, you really have your ear to the ground, and talk to people who are in those everyday interactions on the quote unquote front line. What's that experience been like doing that particular type of research?
Yeah, no, I'm glad you mentioned it. Yeah, this to me, it's been interesting. My first experience out of the doctoral program was working in a big intervention, RCT, out in the community. And one of my first jobs was to talk to the clients that had received the intervention and actually ask them what they thought this intervention was all about. We were talking about psychotherapy. It was all about diabetes and depression. And we were providing them problem solving therapy and antidepressant medication and all these like chronic illness care, all these wonderful evidence based approaches. And when we talked to the clients, it was shocking to see that they didn't tell us anything about problem solving therapy. They didn't tell us anything about antidepressant. It was more about the human interaction they were having with their therapist. It was, and so they were practicing, they were definitely getting better. They were practicing problem solving therapy. They were taking their medication, but that was not what they took from the experience. And to me, that made me really realize, oh my God, if we do intervention, we really need to understand what are people understanding of the things. What is it that they value the most? So that was one experience of the importance of qualitative data to telling me, okay, what's going on. The other piece is the implementation, which was that study was wonderful, but it was like helicopter research. Like we came, we did, and we left. And then what happened? Nothing happened. We proved that the intervention worked, but it couldn't be sustained in a routine practice setting without research dollars. So that's where I was very interested. Okay, how do we implement the evidence-based approaches? How do we bring them to the communities that need them, and how to make sure that they stay there? So how do we go about doing our science in a way that is building the infrastructure, the resources, the capacity, the training that is needed, so that when we leave as researchers, the interventions or aspects of the interventions stay with the community. And a lot of has to do with the way we go about doing our science about it. And then lastly, implementation science, to me, it's sort of where social worker really hits the ground here, because it's how do we implement what we know, the best approach, the best evidence that we have. How do we get that to be done in routine practice settings, and what are the challenges that come in? And that gives you a perspective that is not only about the interaction, but the resources, the infrastructure, the policies that are out there. So it helps us figure that component. And we have multiple examples where we know what to do, we just don't do it, or we don't have the resources to do it. COVID-19 is a good example of that. We knew what we had to do in many ways, and it didn't get implemented in time to address some of this. So knowing what to do and doing it are very different things. So how do we bring that together? And we have examples of that for other types of illnesses and issues that come into play. So it's that gap between research and practice, how to bring that closer together. Yeah.
The no-do gap, as I've seen it termed.
Exactly.
Yeah. No, that's fantastic. I use the word right at the top of our discussion, meaningful, and from the outside looking in, it really seems like your research is truly meaningful and practical, looking at issues on the ground rather than just keeping it in an ivory tower and helping people who need it most. So, yeah, thank you for
I
that.
appreciate that. And part of this, and it is not just my work, Indy, this is part of I'm just representing one huge team of individuals, students, people with lived experience who've done this work, and the community partners that we have. Because at the end of the day, it's what's happening in routine practice settings in the community that we have. So that's one of the approaches. I have an opportunity to talk about it, but it's really the work of many different individuals and groups and students have done this work.
Well, is there anything finally, Leo, you wanted to share with listeners?
I think that, I'm glad you mentioned that. I think there's two things, Indy, and one has to do with, like, we talked about this inequity, the disparity, or the inequity of health. And one thing that we do need to do a much better job, and actually, one of the things before we started recording was one thing that in Australia people are doing is thinking about prevention. Thinking about when a person have a serious mental illness, when should they be thinking about their physical health? And in Australia, with the keeping the body in mind, it's really the first moment you get exposed to an antipsychotic medication. That's where we need to be talking about physical health, combining that so that we don't wait until diabetes happens. We don't wait until you have hypertension. We're actually integrating physical and mental health services from the very beginning. Jackie Curtis has this wonderful quote that I tell everyone, not just screen, but intervene. Like we need to be screening for this issue, but we also need to be intervening. So if I had my magic wand or whatever, it's you get exposed to an antipsychotic medication, you get a lifetime intervention immediately. Like those things need to go hand in hand. We need to be talking about health and physical health from the very beginning. One must live with the other. You need health with your mental health. You need mental health with your health. So those things very well integrated. So I think that's one element that we're working on, the prevention. And this hit me really hard, seeing sort of in many of the studies that we're having, seeing people in their 50s, in their late 40s, early 50s with major chronic illnesses that we're treating. It's like, oh my God, we needed to do something way before when these persons were entering the mental health system. So that's one element. The other one has to do with the social context. That's the other thing that we don't pay attention to, where people live, where they play, what they eat, where they exercise, that social environment around them, and interventions to help make things healthier choices, the better choices, the easy choices for people. And that's one area where in the serious mental illness where we're not doing a lot of work in that. Like we really need to be thinking about food environments and physical activity environments and jobs for individuals, because it's the whole person. And that one, I'm still struggling with that one. That one takes a lot of different types of intervention that go beyond the mental health system to address these issues. So those are two things that I would say. Yeah.
Thanks so much for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means you've gleaned a ton of value from today's episode, or you've fallen asleep. I sincerely hope that it's the former, and if it is, I would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you care about. Our mission here at the Mental Wellbeing College is to provide a free and accessible resource for people to take action and implement to improve their own mental wellbeing. And you subscribing, following, and or sharing helps us to achieve that mission and to impact people in need. Thanks so much for tuning in. It means a lot. We'll see you next week on the Mental Wellbeing College.